I'm Jamie Tung. I'm one of the trauma surgeons here at Stanford. This video is intended to guide you through the steps of performing a primary and secondary survey, usually the role for a junior resident on the trauma service. Alright, so the first parts of the trauma survey, your patient will be brought in by EMS generally. You'll listen to a report, and your trauma captain will tell you to begin your primary survey. We're starting with A, airway. Hi, what's your name?
I'm Andrea, nice to meet you.
So if someone's speaking to you, you know their airway's intact, and you yell out, airway intact. Next, you listen for B, for breath sounds. Big breath for me. Breath sounds clear bilaterally. At this point, I might make note that there's no tracheal deviation, as attention pneumo is part of B for breathing. Next is circulation, where I ensure that my patient has a pulse by checking a central pulse, typically a femoral pulse. I also ensure there's no gross bleeding, and that they have check on what type of IV access they might have. And I might say, circulation intact, no gross bleeding, 18 gauges bilaterally. Next is disability, where I want to know a GCS and a gross motor function. Do you know where you are?
Yeah, I'm in the hospital.
And then can you wiggle your toes for me? If someone is obtunded, I worry about a traumatic head injury. I may also look at this point, look in their eyes for pupils. GCS 15, grossly neurologically intact, pupils equal and reactive 3 millimeters. Next is E for exposure. But hopefully your team has completely exposed the patient at this point in time and placed warm blankets. After your primary survey, your trauma captain may ask for additional adjuncts such as a chest x-ray or a FAST. To perform a secondary exam, you're going to look head to toe. Now you're not looking for life threats. You're looking for major injuries such as femur fractures, long bone injuries, or things that might change what you CT scan or not. So starting with the head, I run my hands through the scalp, looking for any signs of trauma, such as deformities, contusions, abrasions. I look into each ear. No hemotympanum. No hemotympanum on the right ear. I would call out my findings as I go. No evidence of trauma to the scalp. I look in the eyes for any signs of trauma. Pupils equal 3 millimeters bilaterally. Look in the nose. No septal hematoma. And I ask the patient to bite down for me. Can you bite down for me? Which excludes a large mandible fracture. Now I also push down. No mid-face tenderness. Dentition intact. We've generally checked the neck for tracheal deviation during a primary survey, but I can be thorough and do it again. No tracheal deviation. Next, I move to the clavicles. No evidence of trauma to the clavicles. No evidence of trauma to the sternum. Take a deep breath for me. And out. Next, I would feel the chest wall to make sure there's no rib fractures. Chest wall intact, no evidence of trauma. Next, I'll perform a standard abdominal exam, looking for rigidity, or tenderness, or seatbelt sign. There's no evidence of trauma to the abdomen. Next, I perform a pelvis exam for looking for an open book pelvic fracture, which you may also do during a primary survey if you have concerns for this. You push down once, and then in one time. Pelvis intact. Next, we go down to the lower extremities, where I'm looking for a large femur fracture or a long bone fracture. I'm actively trying to displace the bone. No evidence of trauma to the left lower extremity. Next, I move to the upper extremities last, where I'm trying to feel for anything I might want to image via CT or X-ray, and actively trying to displace any fractures. Nothing hurts. No evidence of trauma to the left upper extremity. The last portion will be to roll the patient if we have not already. I would examine the back of the scalp, just like examine the front of the scalp, looking for any deformities, contusions, or abrasions, tenderness, So if there's nothing, no tenderness to the scalp, and then you check the C-spine at this point in time. I'm going to push on your spine. You tell me if anything hurts, okay?
Okay.
No C-spine tenderness. Next, I would take a look at the back grossly, just to make sure there's no large injuries to the back. And then I would similarly palpate the rest of the back, pushing on each level of the spine. No spinal tenderness, step-off, or deformities. Next, I would perform a rectal exam only in the obtunded patient, or someone that I'm worried about a pelvic fracture that's caused injury to the rectum. Otherwise, in an intact, neurologically intact and awake patient, there's no real reason you have to perform a rectal exam.
Okay, everyone, I'm Dr. Skeets. I'm going to be the trauma captain today. We have a 25-year-old female coming in after an auto versus pedestrian accident. She is complaining of left arm pain. She reportedly has normal vitals in the field. She's GCS 15. Dr. Anderson, today we are short an ER nurse, so if you could help with the patient on the monitors, you're also going to be our procedure doc, putting in IVs and any lines or chest tubes as necessary. Dr. Tung, our intern, is tied up, so if you could perform our primary and secondary survey for us.
No problem.
Okay, thank you, EMS, for the report. Dr. Tung, can you proceed with your primary survey? And Dr. Anderson, if you can proceed with the FAST at the same time.
What's your name?
Andrea.
Andrea. I'm going to take a look from your head to toe, okay?
Okay.
Airways intact. Take a deep breath for me. Breath sounds clear bilaterally. Femoral pulse intact. No evidence of gross bleeding. 1 IV 18 gauge to the left upper extremity. Andrea, can you wiggle your toes for me? And do you know where you are?
Yeah, I'm in the hospital.
Yeah. And what were you doing today?
Walking, and then I got hit.
GCS 15, grossly neurologically intact.
Good, thank you, Dr. Tung. Our primary survey is unremarkable. Our GCS is 15. Dr. Anderson, what's our FAST exam looking like?
EFAS negative.
Great. Our vital signs, our heart rate is 70 and our systolic is 110 over 70. Given that she remains stable, let's proceed with our secondary survey. Dr. Tung, what adjuncts are you planning for at this point?
I would plan for a chest x-ray and a pelvis x-ray as well.
Okay, our chest x-ray and our pelvis x-ray appear normal. So Dr. Tung, could you please proceed with our secondary survey?
Okay, I'll pursue a secondary survey. No evidence of deformities, contusions of the scalp. Pupils are equal and react to 3 millimeters bilaterally. There's no evidence of hemotympanum to the left ear. There's no evidence of hemotympanum to the right ear. There's no midface tenderness. There's no septal hematoma. Can you open your mouth for me? Dentition intact. And bite down for me. No malocclusion. Trachea remains midline. No tenderness to the clavicles. Deep breath in and out. No evidence of trauma to the chest. The belly is soft. No seatbelt signs. No rigidity. Pelvis is stable.
Ow!
There is an obvious deformity and tenderness to the left lower extremity at the level of the tibia. Two plus DP pulses, 2 plus PT pulses. No evidence of trauma to the right lower extremity. No evidence of trauma to the right upper extremity. Bilateral radial pulses intact. No evidence of trauma to the left upper extremity. Only positive findings is tenderness and deformity to the left tibia.
Okay, let's proceed with rolling her to check her back. Dr. Anderson, can you please hold C-spine?
Yes.
And we'll have someone support her lower extremity as we turn as well.
Going to the trauma to the back of the head. No tenderness to the C-spine. No tenderness to the T-spine. No tenderness or step off to the L-spine. So the rest of the back is grossly negative for injuries.
Dr. Tung, can you please summarize our secondary findings, please?
Secondary findings, we only have an isolated injury, apparently to the left tibia, with distal pulses intact.
Okay, what imaging would you like?
I think we should continue with our plan for CT, as well as obtain some x-rays of the left lower extremity.
Good. So let's go ahead and get a CT head, CT neck, CT chest, abdomen, pelvis. We're also going to get plain films of her left knee, tib, fib, and ankle. Dr. Anderson, if you could please put the patient on a transport monitor and check and see if CT1 is ready. Dr. Tung, if you can please accompany the patient to CT.